When cellular proliferation escapes regulatory control, the clinical response requires an agent capable of halting division at the most basic molecular level. Welcome to Fresh Vitals. Today, we are examining cyclophosphamide, a high-efficacy, broad-spectrum anti-neoplastic alkylating drug. Its indications within the lymphatic system are extensive. It is deployed against Hodgkin's disease, Burkitt's lymphoma, and various mixed cell-type lymphomas. For hematological malignancies, it is indicated to treat multiple myeloma and a wide range of acute and chronic leukemias. It is also applied against solid tumors, including adenocarcinoma of the ovary, breast carcinoma, and disseminated neuroblastoma. While it exerts high efficacy on its own, clinicians most frequently integrate it concurrently or sequentially with other anti-neoplastic drugs to maximize tumor lethality. Its ability to combat such a wide array of cancers stems from a mechanism of action that requires a precise, multi-stage metabolic pipeline to safely execute in the human body. Cyclophosphamide is a prodrug. The administered compound is biologically inert and entirely harmless until it undergoes metabolic activation. The first physiological step is systemic transport. The inert cyclophosphamide molecule travels through the bloodstream directly into the hepatic system. Inside the liver, cytochrome P450 enzymes initiate biotransformation, oxidizing the parent compound and cleaving it into distinct intermediates. This process yields the primary active alkylating metabolite, phosphoramide mustard, which exits the liver to circulate systemically. This cleavage also produces a secondary byproduct called acrolein. While inactive against tumors, acrolein will become highly clinically significant during the elimination phase. The active phosphoramide mustard enters a rapidly proliferating malignant cell and breaches the nuclear envelope. Here, we see its definitive pharmacodynamic action. The active metabolite physically cross-links the tumor cell's DNA strands, permanently locking them together. Because the DNA cannot separate, this physical clamping directly interferes with the transcription and replication phases of the cell cycle. Unable to divide or repair the structural damage, these highly susceptible, rapidly dividing malignant cells undergo targeted apoptosis. The mechanism guaranteeing its broad-spectrum tumor lethality, indiscriminate DNA cross-linking, is exactly what strips away its cellular specificity, directly causing its severe systemic risk profile. In the clinical setting, dosing relies on the patient's baseline physiological state. We'll examine the initial intravenous course for a patient with no existing hematologic deficiency. For the initial IV dosage, clinicians administer 40 to 50 milligrams per kilogram, divided over 2 to 5 days. Alternative regimens use wider spacing, 10 to 15 milligrams per kilogram every 7 to 10 days, or 3 to 5 milligrams per kilogram administered twice weekly. Regardless of the schedule, intravenous infusions must be administered very slowly. Rapid injection increases the likelihood of administration rate-dependent adverse reactions, including facial swelling and headache. These baseline metrics are only a starting point. Exact regimens must be continuously adjusted based on the specific protocol, the patient's response to treatment, and emerging risk factors. Dosing is highly variable and intimately tied to the patient's real-time physiological tolerance, demanding active clinical monitoring of the drug's metabolic pathway. To understand the strict clinical protocols surrounding cyclophosphamide, we must trace its elimination phase, starting from the liver down through the ureters. Recall acrolein, the byproduct formed during hepatic biotransformation. As it is excreted, it accumulates in the bladder. Highly concentrated acrolein causes severe, localized damage, leading to necrosis, ulceration, and fibrosis of the bladder mucosa. This specific clinical condition is known as hemorrhagic cystitis, a complication that can be fatal. This pathology creates an absolute contraindication. Cyclophosphamide cannot be given to any patient with a urinary outflow obstruction. If the acrolein cannot exit, the toxicity will compound. This risk dictates the first major clinical instruction. Cyclophosphamide should be administered in the morning. During and immediately after administration, the patient must ingest massive amounts of fluid to force rapid diuresis. By inducing frequent bladder emptying, acrolein is diluted and mechanically expelled before it can erode the tissue. Additionally, proactive administration of the drug Mesna is frequently utilized to further prevent severe bladder toxicity. The morning dosing protocol is not arbitrary. It is a direct mechanical necessity to ensure continuous daytime diuresis, mitigating fatal localized urotoxicity. Because cyclophosphamide's mechanism cannot distinguish between malignant cells and rapidly proliferating healthy tissue, it creates broad off-target damage. The most common baseline adverse reactions reflect this disruption to rapid cellular turnover: alopecia, nausea, vomiting, and diarrhea. The most critical dose-limiting toxicity occurs in the hematologic system, presenting as severe myelosuppression and bone marrow failure. Extreme reductions in leukocyte and neutrophil counts strip away the body's primary defense mechanisms, resulting in severe immunosuppression. This leaves the patient highly vulnerable to serious, latent, and sometimes fatal infections, including sepsis and septic shock. High doses carry severe cardiotoxic risks. Patients can develop fatal myocarditis, supraventricular arrhythmias, and congestive heart failure. Pulmonary toxicities are equally severe. The drug can induce pneumonitis and irreversible pulmonary fibrosis, ultimately leading to respiratory failure. The extreme efficacy of cross-linking DNA compromises all systems relying on rapid cellular turnover, requiring continuous, multi-organ clinical surveillance. We must also account for the clinical paradox inherent to alkylating agents. Because cyclophosphamide mutates DNA, the treatment itself is a genotoxic carcinogen. Patients face a documented risk of developing secondary malignancies, including acute leukemias and bladder cancer, directly resulting from the therapy. It imposes severe reproductive constraints. The drug is highly teratogenic, capable of causing fetal growth retardation, miscarriage, and severe structural malformations. Long-term fertility is also threatened. It impairs oogenesis and spermatogenesis, potentially resulting in irreversible sterility in both sexes. Clinicians must instruct male and female patients of reproductive potential to use highly effective contraception for the entirety of treatment, continuing for 4 months post-therapy for males and up to a full year for females. Beyond the pharmacology of the active drug, the intravenous vehicle itself demands specific clinical attention. The cyclophosphamide injection formulation contains a high concentration of ethanol. A standard 50 mg per kilogram dose delivers a significant load of alcohol directly into systemic circulation, affecting the central nervous system. Patients must be strictly warned that this ethanol content can significantly impair their ability to drive or safely operate machinery immediately following their infusion. Mastering cyclophosphamide requires the clinician to look far beyond the tumor, actively managing a cascade of compounding risks that affect the patient's entire systemic physiology and daily lifestyle. If you found this breakdown valuable, subscribe to Fresh Vitals and share this with your medical colleagues.